Good morning. So, good news, bad news. Good news is I got approved to take the RCES. It did take quite some time, but bad news is I was kind of prepared to do my RCIS first. So I haven't really looked at this in a little while. So, I'm building the RCES study guide at the same time, and I already had a lot of that outline written out, and I thought maybe I would have it done before I'm at this point. But what we're just going to do is use my building of it to help me study at the same time. So I have the typed topic list. I just kind of retyped it to help me form my outline, but I did go ahead and print it online as well, which I highly recommend you do so that you can get the list of topics in the exam matrix, the knowledge list as well, and just do kind of a self checklist. So that's what I'm going to work on today. I'm going to do one section at a time. So the knowledge list is really general and just in alphabetical order. So instead of that, I think I'm just going to go exactly to the examination matrix and task list and look at the oh, this is supposed to be the last page. Why didn't this print in order? And I'm going to look at the topics first, but this being in page order would probably be helpful. 5, 6, okay. And we're just going to start with pre-procedures and knock these out. I'll let you guys see a little bit of my note taking and what that looks like. So I am going to film when I remember. I've been studying passively for about a year now, from when I started to make the EP manual, because I knew I wasn't going to have an RCES study guide right away. I wasn't ready for that. But I said, well, I did look at the topic list ahead of time to try to incorporate some of the topics into the EP orientation manual, because I knew that would be out for probably a year before an RCES study guide was out. So I made a point to include a lot of the pharmacology that's reviewed here, some of the filtering things, some of the pacemaker stuff that maybe I wouldn't have included otherwise. And then we're just going to figure out how much exactly I don't know and film the whole thing, for better or for worse. Wish me luck. Now, what you're going to see me do here is write a line or a sentence from the topic list and then dissect it out. So let's say just radiation safety. Well, what are all the things that could be asked about radiation safety? Lifting up the table, putting down the table, how that affects your exposure. Where does staff get their exposure from? Where does the patient get exposure from? What are collimators? How are they used? What are wedge filters? How are they used? And you're going to see me go through a bunch of line items and just do that over and over and over again. And number one, if you have a study guide, the study guide should dissect a lot of that out for you, but you might want to take it a step further. And then you want to write explanations of why we do certain things, okay? Why do we do it this way? What is the benefit of that? Why do we not do it this way? What is the downside of that? And type out those notes so that they're not just in your head. And when you're going back and checking things off of what you see you put an explanation. You go, okay, not only do I know that, but I know the reason why this is correct, and you can check that off and move on. So this is just my initial brain dump of what I personally do. Again, I worked from a blank document, but if you are working from a study guide, this is what you're going to do in addition to the line items already there. You don't just want to read something as is, you want to write your reason why, so that, again, when you go back, you visually see you spent time on that, you understand the reason why, can check it off your list and move on. Then if you do not know something, which you see I have on the document on the right hand side, I put it in red, and I know later on that, remember, my first pass, I'm just going through what I know. My second pass is going to be, here are the things I highlighted I don't really know and don't fully understand or can't think of ways to dissect this out of what I might be asked. I need to go back later and spend some time on this. And then later in the video, you'll see there are some key topics, especially with implants, pacemakers, programming, that I spent a lot of time on because it was not something I was exposed to or knew a lot about. And I couldn't think of things that could be asked because I didn't know enough about the topic yet. And that's what you're spending this time doing. right? Is highlighting those things that you need to spend time on later, and that is going to be part of your strategic studying later on. And you're going to see I'm going to pick about 15 to 20 topics that I am not strong in or I've never heard of and I need to spend time on to bridge up those gaps. All of this stuff I'm writing out is so that I write it out, improve my confidence in what I do know so that I'm not rereading it over and over again when I don't have a lot of time and I'm trying to be strategic in my studying, because unfortunately what you can do at some point is reread things you already know. And unfortunately, if you only have 2 hours in the day, maybe you wasted a whole hour doing that, you're not moving the needle forward. Good morning. I got my authorization to test. Lily thinks I'm talking to her. I got my authorization to test from CCI this morning. So it is February, end of February, and I have 90 days to take the exam. And so that brings me into May. And then I'm gone for a lot of April. So I'm going to say it's looking more like 2 months. I mean, I guess I'll still study when I'm out of the country, but I'm in Korea, which is not even an English speaking country. I am practicing my Korean, so I'm going to have to work a little harder. I have been passively studying a year and a half, as long as the EP manual's been out, and as long before that I was working on it, because I had the topic list printed out and I made sure to include a lot of that in the EP manual. So I was kind of passively studying, but then I switched back to the cath side of things because I was working on the coronary intervention and CTO manual for a long time. So I kind of shifted my focus to that a little bit. And, your brain can only hold so much. There's quite a bit of EP stuff I need to review, especially device programming, because that's just something I'm not super confident in, that is on the topic list and I know is on there that I need to spend a little time on. I buckled down and tried to organize my notes a little better, and I made it through almost all of the pre-procedure section and a lot of the therapy section because I did a lot of my ablation notes. I think there's 2 others that I need to spend a little more time on, and that's what I'm going to do today and tomorrow over the weekend, and I'll update you on my progress. But I did like 4 pages of radiation notes because that's something, again, you're thinking about every day, but not on that level. I did a lot of the monitoring notes, a lot of the troubleshooting notes on filters and connectology, and then complications for some reason. That was what came next. And then my ablation notes. So I have quite a bit more to do, and I'll update you as I'm doing that. But wish me luck. Actually, I don't even know if you can hear me, but this is clocking in. Day 1. Prepare patient for procedures, IV access, interrogate the CIED, cardiac implantable electronic devices, position the patient, patch placement, and monitoring equipment. So I'm going to do the monitoring equipment as far as like blood pressure cuff and tidal, where all that goes, and then patch placement, not just for 12 lead, but like grounding pads, probably mapping patches also, and preparing the procedural site, sterile technique, drape, and insertion site. So where we're going to drape based on what we're doing, because it could be an implant, could be an SICD, EVICD, or it could be femoral access for EP study or ablation. So let's start there. All right, we are sticking to the plan of going section by section. We have moved from pre-procedure. We did a little bit of the adjunctive ablation therapies, and now we're going into interprocedure. Same thing. I have a little snippet of the topic list. I'm going line by line. I'm going to highlight things in red that I am not comfortable with and look into and research a bit later, and then I'm crossing off on the left-hand side of my paper as I go through section by section. And just like we planned, I identified a really big weakness of mine, our 3D maps, something I've not spent time on before, and I'm going to need to over the next couple of days. Good morning. So I scheduled my exam, and this won't post until I either pass or fail, but it's for March 31st, which is about 30 days from now, because I forgot how hard it is to grab a day. So I have to test before May. And in the 3 testing centers that are 20 miles, well, really under 40 miles, because after that it jumps to like a 2.5, 3+ hour drive. there are only 2 days. So it was April when I'm in the middle of my international trip, or March 31st. So March 31st it is. And I do have 59 pages of my study guide done. So I've pretty much run through everything except for the last, I think it's the post-procedure section. But today I'm going over, I think pacemakers and interrogation of devices is the thing I'm least competent in, because I just didn't, besides the basic modes, like I didn't really do anything from the rep side, the interrogation side of things for the EP manual. So although I am going to use this to look over the pacing modes, I really needed to look into Eric's book, some of the pacing ICD, Ellen Bogan book, which I did use to write the pacer section of this, but I need to pay a little more attention than maybe I did the first time around. So today's challenge is going to be understanding a little more this device settings book and being able to remember and recall it, and then comparing this to EKG strips, and can I figure out what the mode is based on the EKG strip. So that is today's task, and it is February 28th. And then yesterday I sat down with Shauna and we went over filters. So notch filters, filters for the amplifier, for high pass, low pass, and clipping, and understanding what those are and what those parameters are, how you set them, what they should be set at, what their purpose is, how to improve signal quality and kind of reduce additional noise, why that's important, and all of the signal recording stuff. So that is checked off my list, and we move on. Let's play my favorite instrumental music by Vitamin String Quartet while we study for probably the next hour. I have about an hour this morning to go through all of this, and that's how I like to study. I like to do it in 2-3 hour segments a day, maybe a little less than that, depending on what I'm working on. So when I was learning refractory periods, I was trying to remember what I am looking for, or really looking for being absent in each of them. So I came up with this. So AERP, so these are effective refractory periods. You're looking for no A, loss of the A. AVNERP, so AV node is from his to Purkinje system. So AV node does not work. So then you lose the H and the V. VERP, no V, loss of the V. VAERP, if you do those, if you have retrograde conduction capabilities, pace until there is no A. So no A, no AV node does not work, no HV, no V, and no A for VA conduction. And you can find more like that in the EP Lab Visual Orientation Manual, but if you have any fun tips like that, drop them in the comments. Good morning. It's early doors, and on my list today are indications of procedures. Again, something you probably know or have an idea of, but I like to fact check myself. Sorry, I know I'm shaking the table. So let's look. We need to do EP study indications, pacemaker indications, CRT, and ICD indications. So Fogros first, because I know they're in here, and I couldn't really find a publication outlining everything I needed to. My dog is on my lap. All right, let's take a look. Cue music. So weirdly, I found indication for pacemakers first, although I was going to get that out of the Cardiac Pacing and ICD's Kenneth Ellenbogen book. But I guess I'll take notes here and then I will compare the two. So I'll read them off real quick. Indications for pacemakers. Symptomatic sinus bradycardia. And there's caveats to each of those. So symptomatic sinus bradycardia at rest, inability to increase the sinus rate appropriately with exercise, thus limiting exercise capacity. Syncope of unknown origin in patients who are shown to have significant sinus node abnormalities on EP testing. Okay, so we're putting syncope under symptomatic sinus bradycardia, or I guess symptomatic sinus bradycardia, and the symptom being syncope. AV conduction disease, so atrioventricular conduction disease, from acquired third degree AV block, second degree AV block below the AV node, so second degree AV nodal block if persistent and symptomatic, new bilateral fascicular block, so the anterior posterior fascicular block. New bilateral fascicular block following an acute myocardial infarction, congenital complete heart block with severe bradycardia, significant symptoms or wide QRS escape rhythm, marked prolonged HV interval greater than 100 milliseconds or a split hiss. Other indications for pacing: cardioneurogenic syncope, so vasodepressor syncope, so where there's a severe persistent component of bradycardia in patients whom more conservative therapy attempts have failed, syncope of unknown origin in the presence of bilateral fascicular block, bradycardia-induced ventricular tachyarrhythmias, and then CRT is indicated for many patients, that's cardiac resynchronization therapy, with significant left ventricular dysfunction and wide QRS complex. CRT is discussed more later. There's a lot hopping around in here. Okay, but let's do symptomatic sinus bradycardia, AV conduction disease, cardioneurogenic syncope, syncope of unknown origin, bradycardia-induced ventricular tachyarrhythmias. And I think that covers it, and then we'll compare it with the other book. Okay, we have those added, and up next are going to be, I should have moved those down here to PACER. Then we need to find the EP study indications. Okay, so I can't find it. The pacemaker indications are in the EP study principle section. And sorry, my dog's jumping off my lap. Okay. I cannot find outside of inside the specific arrhythmias truly outlined indications for an EP study. I mean, I know like unexplained syncope and that kind of stuff, but I really wanted something a little more explicit. And so far I can't find it. So if you guys have this edition and you know what page it's on, I mean, my book and studying will probably be done by then, but I still would like to find it. Oh, what is this? Oh no, mechanisms. And now we're in ventricular arrhythmias in the back of the book. VT, AFib, no. I don't know. All right, well, I guess I need to do a little online research and report back. So this is a Stat Pearls article only with 2 authors, but it's 2025. But I don't love using these as primary resources, but we'll use this for now. In conjunction with a non-invasive diagnostic assessment, the evaluation of cardiac arrhythmias is the main indication for conducting an EP study, right? The purpose of an EP study is to evaluate cardiac arrhythmias. It can provide diagnostic and prognostic information in the assessment of sinus node dysfunction, atrioventricular conduction abnormalities, supraventricular tachyarrhythmias, and the result of an ablation procedure. So this is why I don't love this, because that's not necessarily an indication, like just because they have an SVT, they're going to get an EP study. I mean, you should be evaluated by an electrophysiologist, but it's an invasive procedure. So other things have to be done, certain symptoms have to be there, or hemodynamic instability. So I'm not finding anything outlining that in the way that I like, so I'll keep looking. Okay, well, at least I found absolute contraindications, even though I have yet to find indications in any of the books. Even then, this was an American Heart Association journal. So we say unstable ischemia, bacteremia or septicemia, makes sense. Acute decompensated congestive heart failure, but there's caveat, not caused by an arrhythmia, or not caused by the arrhythmia, the one you're worried about. Major bleeding diathesis, diathesis, I would say that word wrong, and lower extremity venous thrombosis, if you're accessing femoral vein. Appropriate use of invasive EPs therefore require a careful pre-procedural assessment to ensure the patient is stable and able to tolerate the procedure. Oh, it says general indications for invasive EP studies were recently described by the ACC/AHA Task Force on Practice Guidelines in conjunction with who? NASPE. That's the North American Society of Pacing and Physiology. This looks old though, but it's so far I found nothing, so I'm gonna take a look at the article it's referencing. Guys, this document, no publication that I've found for general indications for EP studies and guidelines, besides the HRS one that I reference a lot in here, but that's more so about the safety, your lab, your equipment, just standards for the process and protocols. This other one, just for other general guidelines, indications, contraindications, hasn't been updated since 1995 and is still referenced in 2025 publications. I mean, maybe it just is relevant, but it's so old, there isn't even a digital, when I download it, it's a PDF that was scanned. All right, RCES day before check-in, part 1. Okay, so how am I feeling right now? It's a great question, obviously. I was stressed. I'm a little better now. You know, day before, I don't really like to study. I like to kind of take a mental day of hyping myself up, of trusting what I have done thus far, of, you know what, I've done, well, as you guys know, my prep was not 90 days like I liked. It was kind of a 30-day prep and maybe like a 20-day high-level learning. So what I decided to do, because my original plan was a little derailed, if you followed along on TikTok at all on my vlogs, of just, you saw I spent about 1 to 2 hours of 20 days studying something, 1 or 2 things high level. So then in my mind, I'm like 20 times 2 is about 40 topics that I targeted as these things I don't feel comfortable with, or these things I've never seen before. And I spent those time on those 40 topics learning it at a high level, versus when you're kind of low on time. I've talked to my RCES people about this. You gravitate towards the things that make you feel good and not necessarily the things that are going to move the needle forward. And unfortunately, time is working against you, right? Time keeps going even if you're not making progress. So I really said, I spent the first couple of days completely running through, and I'll have it on here, completely running through the topic list of things that I really needed to work on, and then type them all out. And based off those, identified about 40 things. Well, first, I would say it was about 25 things, 25 topics that I said, well, I don't really know. I know what it is, but I don't know a lot about it. And then through that, it becomes 25, 30, 35, 40 things eventually, because as you start looking things up, you go, oh, actually, these 2 topics are connected and this is how. So then in my notes, I ended up with about 90 pages of stuff. And this is what the strategy that I use to write a study guide, right, is break it down by the topic. Sorry. How do I get this go away? By the section, right? So assisting with therapeutic procedures, and then typing out what's in the topic list on CCI's website from that, and then dissecting out additional information from that topic list to make sure I'm making progress in each category. So I will say My personal heavy hitters, so like the radiation safety stuff, because it's pretty much the same. I mean, radiation safety is radiation safety on the RCES. I was pretty familiar with that. So I typed it all out that first day that I went through things, just to type out everything that I knew, all the inverse square law, use of collimators, lead thickness, reporting, checking the dosimeter, where the dosimeter is supposed to be, all of that, how to increase, decrease dose, increase, decrease urine exposure and scatter radiation. All the monitoring equipment stuff, again, I know it, I just need to type it out. ETCO2, blood pressure cuff, 12 lead, your cables, what needs to be in the anesthesia cart, what needs to be in the emergency trays, location of your 12 leads, like all of that stuff I pretty much knew. I just needed to type it out and refresh myself, but they weren't things that I said, really need to spend time learning this. So let's go over some of the 20 topics that I identified at the time that I needed to go through. Number one was devices. So I did notice in the conducting intraprocedural activity section, there was a lot about devices, about interrogation of devices. And honestly, I said, you know what, if I looked at a pacemaker interrogation screen, I wouldn't know what I'm looking at. So I need to spend time on that. And I did. And through that, I learned a lot more about threshold, lead placement, impedance problems, and all of that was on here on my list. And then let me bring it up. So I watched some YouTube videos and said, you know what, I need to be familiar with these screens and recognize when we're just looking at the lead electrograms that you can tell what's sensing, what's pacing, what the documented threshold needs to be when they're performing a threshold test. And then through that, I learned about Ohm's law. And then I made something for Ohm's law because, you know, formulas are memorization. So I said, Ohm's law is very interesting with a capital V, capital I, capital R, because V equals I times R, impedance times resistance. So I thought that was fun. And then that was a heavy hitter. Then we did the vlog on undersensing, oversensing, which isn't just for the programmer side, but also just on an EKG strip. Can you tell when that is happening? Pacing modes. And then my next thing was maps. I was not super familiar with maps besides the basic ones. And my question was, I can recognize, right, the left atrium, and when we're doing PVI, I could recognize the right atrium and a CTI line because it's by the tricuspid valve. But if I was given a map, can I identify all the structures, right? SVC, IVC, the valves, the appendages. Can I identify what side of the left atrium we're looking at, the posterior or the anterior based on the view? And then through that, can I tell if the ablation was successful or not on an activation map? So all of those I had examples of and dissected out a little more. And then I was trying to learn the difference between macro reentry on mapping versus focal, like an atrial tachycardia, versus an atrial flutter on a map. Does the map look any different? So I spent a little time on that. And then needed to research quite a bit about Watchman. So I understood the device, recognizing it on intracardiac echo, but something that was new for me were the anatomy, right? The windsock, the chicken wing, the cauliflower. Like I had heard all those things before, but I didn't make an effort before in learning how to identify them. So I spent some time on that. Intracardiac echo, that was another day. Did a vlog on that. And being able to identify equipment on intracardiac echo, what it looks like, the home view, adjustments from the home view, what procedure they're doing. So I picked out all of those. Transeptal puncture and identifying the structures in the transeptal puncture, not just the right atrium, left atrium, but sometimes you can see the left ventricle, the mitral valve. So I pulled up some of those examples. All the diagnostic catheters I felt comfortable with. The intervals, I did a vlog on that, on making that on my cheat sheet because that's memorization. And even if you kind of know it for an exam, you want to know your actual parameters. I did some practice questions of effectory refractory period testing and pacing maneuvers. So AERP, AVNERP, VAERP, VERP, and then identifying AVNRT and AVRT, which I've always actually felt a little comfortable with on electrograms. Shauna taught me that really well. But again, it was just something to check off on my list of when I look at other examples, do I actually recognize it? Then I realized, because I used my EP book, because I wrote this book with the RCES topic list in mind, because I knew I wouldn't have a study guide out by the time that I needed to test. So I said, all right, let me put like antiarrhythmics in here, a ton of radiation in here, all the medications in here, anatomy, and then not just intracardiacs, but differential diagnosis, some of the things you want to avoid, Ebstein's anomaly, medications you want to avoid in those patients, patch placement, because I know like PFA isn't going to be on there, but a lot of the other stuff is. Differential diagnosis for flutter and atrial tachycardias I put in there, and complications. So one thing I didn't put in here, I did like a brief page, because it's going to go in the advanced book. Let me find it. I did a brief page on PVC and VT ablations, and really just about the pace mapping and how you're looking for the morphology of the PVC, the different locations that it could be in, and yes, how to perform the map. But I didn't go too deep into it, so I realized I needed to do that now. And Shauna really likes VT, so I asked her to help me identify and understand RVOT versus LVOT location based on V1. So it's the opposite, right? If V1 looks like a left bundle branch block, it's probably an RVOT origin. If V1 looks like a right bundle branch block, then it's probably an LVOT origin. And then I did a recap on after depolarizations, early after depolarizations, and delayed after depolarizations. Even though they're in the manual, it's not something I spent a ton of time on. So I just recapped that. I had to draw some new anatomy that I didn't do before, and thankfully Shauna's doing the right atrial and right ventricular anatomy review on our Instagram, so I just kind of followed along with her, and I tried to find some fun ways of remembering the triangle of Coke. So I put Totes Tacos. I put this one, but it wasn't as easy to remember, so I put Totes Tacos for tendon of Todaro, tricuspid valve annulus, and coronary ostium, coronary sinus ostium. I could improve that a little bit, but I needed something, right? Again, review of Ebstein's anomaly. Parahiscine pacing. Someone asked about that on Instagram, and I wrote little notes from what Shauna taught me on that. Assisting with therapeutic procedures. A lot of that is more the mapping. So the ablation equipment, again, the book was, we did RF and cryo, but it was a big focus of PFA, which isn't really on the exam because it's newer. So, I mean, it wasn't even listed in the topic list. So I knew I needed to learn a little more about RF ablation, the temperature stuff. So like 50 degrees Celsius is what causes irreversible tissue injury. So you need to heat to at least 50 degrees Celsius. And then I was like, oh, I need to know how to convert Celsius to Fahrenheit or vice versa. 100 degrees Celsius is where you get the coagulum formation. So like 50 to 100 is the range that you're looking for. Voltage, 40 to 60 volts to avoid barotrauma, pros, cons of irrigation, all the complications that can possibly happen, indications for those. So I spent a little time on that. I spent a little more time on lead extraction. Again, I put it in the book, but something I just needed to actually look at the indications for and the documented indications for. Endocardial pacing, had never seen it before. I mean, I've seen it in person in like a open heart surgery environment. And we had a patient come post open heart for a code, and they had the leads kind of hanging out from a quickly closed chest. But I had never seen them on fluoroscopy, so I needed to look that up. Post procedures, a lot of that, again, is, in my opinion, very similar to the RCES as far as the list, besides some of the like pacemaker pocket issues. And patient educations for specific things like devices. And that's pretty much it. So that was enough topics that I felt like would move the needle in my studying. And then my goal is, I'm going to manifest today. I am going to pass. When I pass, then I can spend a little more time dissecting out all this information I wrote down that I just didn't spend too much detailed time on because my time was limited and I knew I needed to pay attention to the things I personally was weak in. But obviously when I write a study guide, I need to pretend that everybody is weak in everything to make sure I hit all the points. And so I'll do a lot more detailing on that. So you'll see, like, I wrote out, I had to research tilt table testing because that's not something that I've done before. All of the pacemaker indications, which are different, by the way, depending on what book you're reading. So I just kind of put both and compared them. EP study indications and contraindications, which was a little harder to find than I thought. It's not in any of the books. Pacemaker stuff is. And then, let's see. Wow, I was very thorough in pre-procedure. Honestly, I filled a lot of this out. I mean, it's 92 pages. I just don't have drawings in here because drawings take me time and drawings are more for other people. Oh, for example, I didn't draw out the arrhythmia examples for AVNRT versus AVRT or AVNRT with aberrancy. So I'm going to need to fill out those drawings later. And it will. Normal conduction, I feel good with that. So like the crossing transeptal stuff, those steps are in this book. I just didn't transfer them into this yet. So anything that was in this, I really kept in here, and then I studied it from here, and I'll find a way to pull it into the study guide when I'm ready. But since I have both available, obviously, right, if you're just studying for the RCES, you might not get this. You might just get the RCES study guide, so you don't need both. But since I have access to both, I spent time in this book a lot. And here's an example of a page I spent a lot of time on. Well, a few pages. Action potential. Number 1, spend a lot of time here. And number 2 is right before that. It's in that order for a reason, my antiarrhythmics medication list. And I did a little vlog on that too, of working through that book, on working through the pacemaker modes page. Then I did come up with some fun mnemonics in here while I was working on it. And then I'll update you tomorrow on how it goes. But I'm not overly confident. I just feel like I know enough to reason through things if I'm not familiar with it and take it from there. And then I will review. Oh, so new question. What did I use to study? 85%. I'd say 85% I used the book that I wrote. Because like I said, I wrote it with the intention of the RCES topic list already printed out and making sure to put in little things. So like filters, for example, I know it's not stuff that you actually might be adjusting. However, I put them in here because I saw it on the RCES topic list. And let me show you. Types of filters, high pass and low pass are in here too, but more of the amplifier settings, what is clipping, high pass filters, low pass filters, notch filters, stuff that maybe wouldn't be talked about too much when you're being trained, but because I knew it was on the RCES list, I went ahead and included it in here. So I'd say 80% I felt was covered in here, and then more of the advanced stuff, because this is a foundational book with some different high level stuff in there, but it's not 100% high level, I needed to do. So I have examples of intracardiac echo in there, but I need to put like the basic views of intracardiac echo in here, just anatomy, and go through that. And obviously the ventricular tachycardia stuff, some of the more advanced mapping stuff that isn't in there because it's going to be in the advanced EP manual. So 80% that. All the rest was this, and then my notes. And then I did spend, and I did it on the vlogs, 2 days looking at the, what is it called? Understanding EP workbook, just to do some of the AV NRT, AVRT, and effective refractory period practice, because I'm not getting to see those every day. I think if you're working and you get to see that all the time, or you have full disclosure on all your studies, you can print some out and practice that way. So I hope that helps. We'll see how it goes tomorrow. Weirdly, I have a dentist appointment before because my appointment's in the evening, and if I rescheduled my dentist appointment, I couldn't go for like 6 months because he books out late, and I like to eat, so I care about my teeth hygiene. Yay, team no cavities. And yeah, So if I have anything dental I need to get done, the answer is going to be no, because I have to go to my appointment, the exam appointment, immediately after. I'll keep you updated. So I know it's been a while, I know for the exam I need 2 forms of ID. So I'm going to do my driver's license and my passport. One of them has to have your photo. Both of them have my photo. And your name has to match on everything. So your name has to match on your appointment thing, first and last name, and both of your IDs. I have had alumni that's a problem with for a lot of my people who have 2 last names, and on some IDs they have both their last names and on some they don't. You need to choose 2 that are the same and that matches what you applied with. So if you, let's say you applied and you put, I don't know, Maria Juarez Smith, but your ID only says Maria Juarez, you either need to change the name with Pearson so that they match, or you need to change your driver's license to match Pearson, one of the 2. And I have had people do that. I've had people who had to change their IDs, and people had to contact Pearson to check, because like changing the name on the passport is going to take a long time. So do you even get it in time, or is it easier to call Pearson and do it that way? So just FYI on something people might not think about and might think it's okay if it doesn't match. It is not okay. You do have to change some things around so that all 3 of those items match each other. And I'll see you tomorrow.
I'm in the fight.
Good morning. It is the morning of exam day. It is 7:08 a.m. My exam isn't until 3:45 this afternoon. So, I don't like to study the day of. I'm just going to do my cheat sheet, which I will show later. But I took a shower this morning to wash away all the negativity. I'm going to do a little stretching in a minute. I have my coffee. I'm making my breakfast. And I actually have a dentist appointment at 11:30, which is good because I need to have things to do before my exam so that I'm not just sitting there studying and or worrying all day, be too busy to worry. So we have that. Before that, because it's only 7, right? 8, 9, 10, 11, that's 4 hours before 11. I'm going to do my cheat sheet once. I'm going to pack orders, go to the post office, eat, go to the dentist, probably eat again because I should be done at the dentist by 12:30, and then I need to leave at 2:30 to be at the testing center. So then I'm going to have 2 hours for lunch, and then I should be ready to go. I'll keep you updated. This is Lily. She's wishing me luck. Quick little exam reminders, what you need to have. 2 valid forms of ID, probably a driver's license and a passport. One of them has to have a photo. Both of them cannot be expired. And like I said, those names need to match the names on your appointment form thing. So you need to make sure you have those. I am wearing a sweatshirt. I don't have a shirt under this sweatshirt. If I did, they would, just like TSA, they would make you remove this and only wear the shirt under it. I wouldn't wear a hoodie or anything with pockets, because it is just going through airport security, and the more you have, the more they're going to search. I had my combat boots one year, and they made me take my shoes off and looked at my combat boots and everything. So I'll be wearing sneakers this time. If you have an Apple Watch, don't wear it. If you have Ray-Bans or Meta glasses, Oakley, the Meta glasses, don't wear them. If they're prescription, that's kind of hard, right? Where your readers or whatever, but they're just not gonna let it in. Any other regular glasses that you have on, they are gonna completely scan through to make sure there's no tech in there, nothing written on there. I don't know if they're gonna make me take off jewelry. We'll find out. But yeah, same with I know I'm gonna have pants with pockets. They're gonna make me put my pockets inside out. They can look at that. But I'm gonna make it as easy as possible, but it's cold in there, so I'm not gonna wear a tank top. But sometimes that part really stresses people out because they don't know what to expect. You also can't take in any personal items with you. So obviously if you go in, you have your wallet and your keys, right? You can't take them into the actual testing center. So at the desk, you will put them in a locker, like at the gym, with a code. That's the last thing you need to remember, right? Is the code and what locker you put stuff in. But if you forget, it's okay. Unless maybe you're at a place that gives you a key, that's nice. But the one I'm at, you have to put in a code, so I always put like my birthday or something so that I remember, because I don't need to be stressing out about that while I'm taking my exam. Update, it's 9 o'clock, so I have 2 hours until my dentist appointment. I packed the couple of orders that I needed to, and I'll drop them off on the way, but I felt my anxiety a little bit, so I'm gonna take my own advice and I'm gonna watch a funny BTS YouTube video, and that's what I'll do for the next hour. First stop is UPS, second stop is post office, and I'm parked next to Stark Industries. Oh, penny on heads. All done, easy peasy. Let's go to the post office and then the dentist, and my blemish has a friend and we're stressing out. But I don't know if anybody else does this when you're stressed about something. I schedule things the days after just to remind myself life goes on. So like the Mario Bros. Galaxy movie comes out, and then I scheduled a facial because we're celebrating either way. See them running up, fight, down again. I can feel it go, running through my veins. Holding on my neck, hoping adrenaline. Reported adrenaline. Reported adrenaline. Dentist is done. Still no cavities. And I'm here to pick up a smoothie because I'm super hungry. And then I'll eat when I get home. And we'll work on the second half of our day. 3 hours out. We do the acai berry boost, no turbinado, which is essentially, I think, corn syrup, so no added sugar, and whey protein scoop to keep my brain going. Hi. Back at home. Just to let you out. Yeah. Hi. Yeah. Mommy went to the dentist. Hi. Good girl. All right, guys, we're here. Ominous office building, and I'll see you on the other side. Guys, I passed. Okay, let's do a quick debrief before I don't want to think about this anymore. First of all, it was insanely hot. I regret wearing this. Like, I'm not kidding. It was 90 degrees. I walked in and there was a wave of heat over me. I was like, I'm not a hot-natured person, but I was like, I don't know how I'm supposed to focus. So number one. Number two, yeah, security and everything does take about 10 minutes for them to wand you and do all this stuff, and they have chit chats with you. And that's fine. I didn't really mind it. They were really nice, actually. I got a key for the locker. I didn't have to remember it, so that was helpful. The sheet that you get is more than an 8.5 by 11 paper. I just like to write down things as we're going, almost like I'm rewriting out the question just so I can reason through it. Oh my gosh. I did much better than I thought I was doing while I was taking it. Cause I was like, it's always like that, right? When it's a multiple answer question, like, most of them, but then you're between 1 and 2, but you don't get any credit for partial credit. So you're like, did I get this right? And that's kind of how I felt. There was a lot of things I need to review, like cryo I'm not as familiar with. Some of the RF troubleshooting stuff I'm not as familiar with. And I did write it out. I just didn't remember all of it. And I should have made a mnemonic. Like, I have a mnemonic, but I didn't put it on my cheat sheet for the medications and action potential, and I should have done that. I actually felt really prepared for the echo questions. I felt prepared for the device questions because I knew I was going to be really derailed by that if I didn't study those, because there was so much about it on the topic list. So I'm glad I spent time on that. I'm glad I did not ignore the pre-post stuff, because I think
The 92% in the post really elevated me, and the interprocedural and diagnostic, which is where some of those, the imaging stuff and the, what else? And the device stuff lives. So I'll let you know more when I celebrate. But truthfully, if I did not have Aaron, Matthew, and Shauna to teach me, I don't think I could have passed just off of the books that I read on my own. Like, I really think them, and I'll put that in the study guide, like a lot of the concepts they helped clarify for me, because there's just a lot of stuff on there that isn't really verbalized or said, or you're really trained on. I think it's stuff, it's like underlying theoretical things, if that makes sense. So thank you to Shauna, Matthew, and Aaron for mentally, emotionally supporting me, answering my millions of questions. Shauna, I think I've texted her like every day for the last month on something where I'm like, hey, can you explain this? Or is this this? And is this why? And she'll like kind of correct my theory of thinking.
I didn't make an ending, so in edits, here is one. Good luck if you are studying. I think a lot of these strategies are relevant for any exam you're taking. I'm studying for my RCES recertification because I retake it every 3 years, and I'm going to have the exact same study strategy. It is just what works for me, especially when you are on a timeline. Remember, you are passively studying through work, through school, through your daily activities. You just want a really key highlight focused study strategy on the things that you do not know, but you do have to take at least a week or two of preparation, of running through everything to figure out what it is that you know and you don't know based on what is on the exam. Don't just assume what you do every day is what is asked, because if you don't have experience in other labs do things very differently. Some of them are multimodality labs, and you're going to have to learn some of the stuff the mapper does, some of the stuff the programmer does, some of the stuff the physician does pre and post, even if you don't staff pre and post. So don't forget any of that. Make sure you reach out anytime you have questions on any of our social channels. We will be more than happy to help you. And thank you so much if you watched this all the way through.